Hi everyone. Thanks for your patience. It's really nice to see all of you and to get to share some of my work with you. My name is Maria Dieci. I'm an assistant professor in the Department of Health Policy and Management here at Rollins. I started about a year ago, so I'm fairly new. I see some familiar faces, but some new faces. So it's nice to meet all of you. So today I'll present to you a project on how incentives can be used to improve quality of malaria care. Evidence from Kenyan pharmacies, and this is joint work with collaborators at UC Berkeley, Maisha Meds in Kenya, and Remit Kenya. Let me try this one more time. Yeah, okay. All right, so, and I don't know how I think you do questions at the end, but if you have questions, like clarifying questions throughout, I'm fine with that, so feel free to use whatever format makes sense to you. So the motivation for this project is that in health policy, one of our aims is to ensure that appropriate medical care and treatment get to people who need it, as well as to ensure that unnecessary medical care don't reach people unnecessarily. And in order to kind of achieve this aim, that requires coordination between patients and their care providers, especially in contexts where kind of top-down systems-based coordination may be more challenging. We see evidence of both kind of high levels of overtreatment and undertreatment of various medical conditions around the world, and this can have serious health consequences for patient outcomes, and we've seen this in terms of rising antibiotic resistance, kind of inappropriate anti-malarial use, among others. And often this kind of dual issue of both of over and under treatment is a result of kind of how financing contracts are structured. And so thinking about how these financing contracts are structured and how those shape the incentives of both patients and providers is kind of the motivation for this project. So I study kind of in this work, we study in kind of incentive misalignment and over and under treatment in the context of malaria. Which is an important clinical area to study this question, primarily because it's a very well understood illness with a high disease burden and is characterized by both over and under treatment in many different contexts around the world. The good news is that nearly all deaths in serious illness due to malaria are preventable. We have high quality medication that's widely available across the world, and high quality accurate diagnostic tests, including rapid cassette diagnostic tests, which is the focus of kind of what we'll be using in the study. And these tests and these treatments are available at a variety of different healthcare providers in the public and in the private sector in areas with high disease burden. Unfortunately, the reality is that relatively few patients with suspected malaria actually get diagnosed prior to receiving some kind of anti-malarial treatment. One study found that about only a little bit less than a third of patients actually got a confirmatory diagnosis before kind of being treated presumptively. And this has been shown kind of repeatedly in many different studies in a variety of contexts. And kind of this low level of diagnostic testing is really what contributes to the gap between treatment allocation, kind of, people taking antimalarials and the actual clinical need for those medicines. And this gap kind of has a few different potential downstream problems. One is kind of at a patient level, we might see more serious avoidable illness due to kind of incorrect diagnosis and treatment, delays in getting proper care, and then sort of zooming out and kind of thinking about population level implications of sort of inappropriate antimalarial use. We can think about sort of rising drug resistance, which we're starting to see for the most recent class of first-line medicines in parts of sub-Saharan Africa. So looking at this issue in the context of the private sector, which I realize is kind of often in public health, we think about public sector interventions working with governments and public clinics. In this case, so we're going to sort of think about the other piece of the healthcare provider space, and so private sector providers are where we're focusing on, and this is because they play quite a significant role in malaria medication supply. Not just malaria medication supply, but in this setting, that's the reason for thinking about these actors. Across East Africa, more than about 50% of suspected malaria patients actually sort of seek care initially in the private sector and receive kind of potentially diagnosis, but treatment and medication in these settings. And so they're quite important in kind of how people every day seek care and actually get care for a variety of illnesses. And in these kind of pharmacy or private sector settings, this is one where kind of different motivations of both patients and their providers can interact for suboptimal care from kind of a public health perspective, or when we're thinking about sort of the kind of clinically optimal progression of care. And there are kind of a couple of different reasons why this might be the case. So the first is on the patient side. So when a patient seeks care for a fever or for other sort of related symptoms in a pharmacy or private clinic setting, they may not kind of demand or ask for a diagnostic test because, on the one hand, they might have, they have felt like this before, and so they might have sort of strong beliefs about their illness status and the fact that they actually are sick with malaria. The second is that in these private sector providers, medications and diagnostic testings come at some cost. And so for some patients, that cost might be prohibitive. And so they might choose to forego a test in favor of just buying medication over the counter. And then finally, it takes some time to actually kind of run the diagnostic test and wait for the results to come back. And so patients who might feel time constrained may opt to not get tested. So that's kind of some reasons why testing is low in these settings from the patient side. From the provider side, pharmacists kind of may not offer patients testing in these settings because of their perceptions of patient preferences. So these pharmacists are not only kind of providing medications and care, but they're selling medicines, they're selling drugs, and so they're kind of operating small businesses, and so they're quite sensitive to consumer demands, consumer preferences, and so they might be motivated by these things and sort of choose to not stock and sell tests. And then kind of the second piece, of course, is kind of the profit motivations that don't exist in the same way in kind of many public sector settings that we might be kind of thinking about as alternatives. And so this is kind of the backdrop where kind of the backdrop for this study. And so just to kind of give you a preview of what we'll talk about today. So in this paper, what we do is we test whether financial incentives targeted at either the patient or the pharmacist providers, whether they can increase testing and appropriate treatment for malaria, and kind of assess the cost effectiveness of these different approaches. We do this through a cluster randomized control trial in 140 pharmacies in malaria-prone areas of Kenya, leveraging data on over 50,000 patient encounters over an 8-month period. And so we incentivize testing for malaria, for suspected malaria, as well as treatment for malaria-positive individuals, and kind of experimentally vary whether those incentives are given to the patients or to the providers or to both. And then this, the experiment and the data collection period ran from June of 2021 through February of 2022. And so the data that I'll show to you today is from this period. And so just to kind of preview what we'll find in this paper, so we find that both patient subsidies and kind of pharmacy provider incentives are quite effective at actually kind of encouraging patients to test for malaria prior to obtaining treatment. We find between a 19 and 27 percentage point increase in the uptake of testing across the 3 different arms. We also find that both these discounts and incentives are effective at kind of encouraging patients to the appropriate type of malaria treatment if they're positive. And then we actually find that, it doesn't matter who you target these incentives to. So you can give them to patients in the form of a discount on test and treatment, or to pharmacists in the form of a small kind of performance incentive. We see very similar effects in terms of overall uptake. And I'll kind of show you through some of we kind of go in and look to see, well, why are these interventions working the way that they do? And we'll be able to see that these results are being upheld really by a change in kind of individual patient and provider behavior, sort of when they're coming together to make that sale or make that decision. Okay. So just to kind of give a little bit of context, a very brief amount of context on malaria in Kenya for those who may not be familiar with this setting. It's kind of a country where there's quite high malaria burden. About 3 in 4 people are at risk for contracting malaria, and this disease burden, it's concentrated among poorer populations. Pregnant women and children are most susceptible not only to kind of contracting, but to have some of the more serious health consequences of the disease. And this map over here kind of shows overlays kind of a coarse measure of malaria burden across Kenya. The orange zones are the areas that are malaria endemic, and so they're concentrated both by the coast over here on your right, and then also by Lake Victoria here on the left. And in Kenya, like other high burden areas, there are widely available tests and high quality treatments. So there are a few kind of in Kenya specifically, there are 2 primary channels through which people seek care. The first is, of course, through the public sector. And in the public sector, malaria treatment is actually provided for free at no cost to patients, conditional on receiving a positive diagnosis. And sort of the second, so I guess free testing, kind of free treatment is available in public sector settings. And in the private sector, where a large share of patients seek care, they are tests and treatments are provided on kind of a direct patient copay basis. So this is a setting where kind of out-of-pocket costs for diagnostic testing and medication are borne basically entirely by patients. There's not a sort of a widespread kind of health insurance infrastructure that kind of can offset some of those costs, so that the costs are really cost borne out to individuals. And in the private sector, kind of through decades of, which maybe some of were involved in this, more than I was, of course, but, over a series, over the last couple of decades, there have been large scale global efforts to ensure access to high quality, affordable medicines in the private sector. And so this has resulted in widespread availability of ACTs, which are kind of the first line medication for malaria treatment at reasonably competitive prices. And kind of what I want to show you here in this chart here on the right is these are data from the sample of pharmacies that we worked with from 2018 to 2020, so before the study period, just showing shares of kind of this is transaction level data, so looking at shares of malaria related products by type. And what I want you to take away from here is that, if you can see, so out of all of the anti-malarial products that were sold over this time period, only between 10 and 15% of them were actually diagnostic tests. And so if you're thinking about sort of what an optimal kind of ratio of test to treatment might be, we're in this type of setting, we're really looking for something more like 2 tests to one treatment, because of course not everyone who tests is actually going to test positive, but we see a much lower level of testing than would be appropriate in this setting. So just to kind of recap what we did in our experiment, we ran a cluster randomized control trial across 140 pharmacies. This was a stratified randomization design, and we randomly assigned pharmacies to one of 4 groups, 3 treatment arms and 1 control group. So we had one group of pharmacies that received kind of discounts to patients for malaria tests and treatment conditional on a positive test outcome. A second group where those incentives were provided directly to pharmacists in the form of a small kind of performance pay incentive. A third group that actually gave both patients and pharmacists a kind of an incentive, and then finally a control group where there was just status quo care seeking, so there were no kind of incentive interventions. And the reason that we structured it this way is that we wanted to incentivize kind of the 2-part decision that patients are making, the testing decision and the treatment decision, kind of conditional on that test outcome. And so this structure allows us to look at both of those pieces And then each of the incentive, all three of the incentive arms test basically an incentive amount of the same size. So, the kind of the dollar amount of incentive that's provided in each of the arms is held constant. And so really what we're looking at is kind of the targeting question of kind of who patient or provider or both, should these be kind of how those different targets may result in different outcomes. So this is just a study flow diagram. We started with a potential sample of 255 pharmacies across, and I'll show you a map in just a moment. And then sort of, from our eligibility criteria assessment came up with our group of 140, which were then randomized into these four groups and followed over this period for 8 months. And most of the data that I'll show you today are from the transaction data during this 8-month period. From this group of 140 pharmacies. Okay. Yeah.
Can you talk about how is the client with the intervention monitored? The patient or the pharmacist to do the payment, how do you know?
Yeah, that's a great question. So, yeah, happy to just so for those on Zoom, the question was, how did we assess compliance with the intervention? So if a patient or pharmacist received an incentive, how do we actually know that they actually, did the test and then listened to that test result when making the treatment recommendation? So all of our diagnostic tests through this program were kind of had individual identifiers on them. And as part of the kind of flow, the sequence of sort of protocol steps for kind of getting that information in order to then be reimbursed. Pharmacists were required to upload a photo of that uniquely identified test cassette with that test result clear. And that was then verified on the back end kind of by our implementation team to make sure that that was actually the unique test that was used for that patient. Yes.
And then how did you identify that?
So any patient who sought care anyone who came to the pharmacy and was looking, had fever or had suspected malaria symptoms, they were eligible for the intervention. And so at that point, it was then, it was up to basically the pharmacist to, either offer this type of discounted test and treatment or their status quo standard of care. So anyway, everyone who came in was eligible. Yeah.
The pharmacy, for folks who not really work in countries that have these kiosks.
Yes, great question. And I'm going, yeah. So the question, this question was kind of, can we describe a little bit more about what these, what are these pharmacies? How do they kind of, are they regulated, et cetera? So yes, all the pharmacies that we worked with had to be regulated through the Pharmacy and Poisons Board in Kenya. So these were official licensed pharmacies that had kind of trained, pharmacist level providers. But, they varied in terms of size and also the population that they served. So this is just a picture from one of the pharmacies in our sample. And this is one where, it's a walk-up window. And so, there's a pharmacist that sort of sits behind this window, and then the patients walk up and have their interaction. So these are pretty small establishments. On average, they have, 1 to 3 staff. And our sample kind of varied in terms of whether it served very, very rural communities or were more kind of peri-urban. And so we have a range of locations, and I think you'll see that hopefully in the map that I'll show in just a moment. Yeah. Yes, and then I'm gonna move on. Yeah, go ahead, Sonia. Yeah. Yeah, so 2 ways. So providers, so there were basically posters at the pharmacies that described kind of in general terms what this, there was this program and that they were, eligible. And so the prices for these products were displayed. They also, as part of the kind of registration, they received an SMS message that that was an automated message that confirmed the prices that they should be receiving for these products. And then, yeah, the pharmacist then was kind of also sharing that information. Okay, great. Sorry, where am I? To get back to my slide. I hope that I was sharing my screen with the Zoom folks. I'm sorry if there was technical issues. Okay. Okay. So I think I'm gonna, this is just a slide that shows basically just the breakdown of the incentive interventions that we tested. So, first the incentive amount, I'm happy to talk more if folks are interested about kind of how we arrived at those incentive amounts and sort of what considerations went into that. But the total incentive amount was $2 or about 200 Kenyan shillings. And that was basically either given entirely to the patient in the form of about a 90% subsidy or discount on a rapid diagnostic test, bringing the price down from about $1 to about 10 cents. Kind of the rest of that, the remaining portion of that $2 was given as an incentive on the medication. Or that amount was given to providers, again, both for incentivizing the testing and then the treatment, conditional on that positive test, or that $2 was split roughly kind of 60% going to the patient in terms of kind of those incentives on test and treatment, and then 40% to the provider. So this is a map of where our pharmacies were located by intervention arm. So a couple of things to note. So we focused our study in areas with high malaria burden. So these are all around Lake Victoria. There's there's like quite a bit of spread across 11 different counties. 8 different counties in Kenya, with some pockets where there's a higher density of pharmacies in our sample, namely in Kisumu, which is where that kind of mass of dots is. But you can see there's sort of like, there are areas that are a little bit more dense than others, but this is where the study took place. And there are kind of 3 primary data sources that the results I'll show today come from. The first is the pharmacy transaction data. So pharmacies that were enrolled in the study, part of the eligibility criteria was that they tracked their daily sales and inventory on basically a digital app platform that was entered on a tablet. And so the transaction data from all of the sites came from that source. We additionally have data, again, through this digital platform on malaria testing and treatment decisions from about 8,500 patients who basically opted into these incentivized programs during this period. And then finally, as a way to kind of measure different aspects of quality of care and sort of the patient-provider interaction, we had a mystery shopping data collection activity that, and we use exit survey from that activity from 411 visits in January and February of 2022. So this is kind of very, very briefly on sort of the empirical strategy. This is a randomized controlled trial, and so the methods are not particularly complex. We use an intention to treat framework and that's what you'll see here. And we report our results as marginal effects from adjusted logistic regression, where we adjust for strata and calendar month fixed effects and baseline pharmacy level covariates. And then you'll see we'll report results both from kind of pooled or any of the 3 incentive interventions, and then also look at each of the 3 incentive interventions separately. Okay. So now I'll walk you through the kind of the main impact evaluation results. So looking at sort of the effect of these incentive programs on both testing uptake and treatment decisions, and then explore a couple of mechanisms that we looked at through the standardized patient activity to understand how these incentive interventions were working. Okay. So the first kind of high level finding is that both the demand, so the patient discounts and the provider incentives, improve testing uptake. And so just to kind of, all of the tables will look like this. So just to kind of orient you to what you should pay attention to here. So our outcome is rapid test uptake. So this is defined as out of all of the patients over this 8-month period who sought care for, kind of who purchased a malaria related product or sought care for malaria, how many of them, what's the share that kind of took up a test as part of their purchase? And we report results both for the pooled intervention and then for all 3 intervention arms separately. So the first thing that I want you to note about this is that there's very low testing uptake in the control group. So only about 8% of patients in the control group actually purchased a rapid test prior to getting any anti-malarial treatment. So this is, lower than what we've seen in prior literature, but is kind of directionally consistent with the story of low testing in these types of, private sector pharmacy settings. And we see that's the first thing. And then the second thing is that, when we look at the overall effect of any of the incentive interventions, we find large increases in patient uptake of testing of about 25 percentage point increase in testing over the control group. And then when we look at break apart and look at the differential impact of the patient discounts versus the pharmacy incentives and the combination of the two, we find kind of effects between 19 percentage points and 27 percentage points. And then when we sort of formally test for any differences across these different arms, we find that all of them, we can't reject that they're all, that they don't have any differential impact from each other. Okay, so we find sort of significant increase in testing. And of course, that's only good if people actually listen to that test result when making their treatment decisions. And so, of course, kind of thinking about the ultimate goal of this. So we want to understand what are the implications of this increase in testing for treatment adherent, or kind of for treatment decision making in this patient population. And so what we find is that, again, kind of all of these incentive interventions improve ACT targeting. And I'll kind of walk you through each of these columns in turn. So the first outcome that we're focusing on here is overall uptake of ACTs. And we find basically an overall decline across all three intervention arms in essentially patients purchasing ACT medication. And so, that might be somewhat puzzling, but we kind of need to basically break this outcome down into its components in order to really understand what's going on and whether this decline in testing, in treatment uptake, is a result of people who are basically not getting treated, who didn't need to be treated, or whether we're seeing something else going on. And so we do that in a few different ways. And the first, I'll talk through the first two just now. So this overall ACT uptake can basically be broken down into two components. The first is ACT uptake with a confirmatory diagnosis, so patients who purchase ACTs with a diagnostic test. And the second is the people who purchase ACTs without a diagnostic test. So basically just get the treatment, just get the medicine without any kind of diagnostic information to base that decision off of. And what we find is that when we look at these two kind of the component parts of that overall uptake outcome, we find kind of overall, in our pooled arm, we find an increase in uptake of ACTs with a test. So we find that there's some intervention effects on kind of increasing the share of patients who are kind of purchasing ACTs with a test. And then, just one second, and then in the last two columns, we find kind of this overall decline is largely due to a large decline in individuals purchasing these medications without any kind of confirmatory diagnosis. And again, we don't find kind of any differences across the incentive interventions, so the patient discounts, pharmacy incentives, or both. Yes?
Is this conditional on the result of the test?
I will show you that next. Yeah, so yes, great question. So just a note on this table. So these are this slide and the last slide I showed you were the level of analysis was at the individual patient level. So we're looking at individual transaction data. I don't have test result for every single person in the sample who tested. And so the question was, is this conditional on the results of the test? And so what we're able to do with looking at the kind of how the positives and the negative test results kind of break out is I'm looking at changes by test positivity rate at the pharmacy level. Since I don't have individualized kind of, I can tell you for whom I do have individual testing information, but it's not for the full sample. So yeah, so the base was a good question about whether these tests were, whether it's kind of having a test at all or having a positive test result. And that's what we looked at here. So the question is, whether or not patients actually act on that test information, so the negative or positive status. And so the next set of results, again, is looking at this question using a kind of a pharmacy level analysis. So this is a slightly different outcome. So instead of looking at treatment uptake at the individual level, we're looking at kind of the share of ACTs sold at the pharmacy level. And first, kind of this first column basically just reproduces the this finding. So it's sort of the equivalent of the kind of just overall change in treatment sales, but again, by the pharmacy level. So we see again this kind of consistent overall decline in the share of ACTs sold over the study period. But of course, this is potentially masked by positive and negative test results kind of sorting differentially. And so that's what the kind of these next two columns are looking at. And I'll just kind of focus on this third one for the moment. So what we do here is we in this model, I'm interacting kind of the intervention or sort of the treatment with the test positivity and test negativity rates that we find in our pharmacy samples. And what we see is that essentially what we find is that the information matters for patients. And in particular, for kind of more patients who are testing negative, we find a much larger decrease in kind of ACT sales. And so the negative test results are really kind of the people that are sort of being deterred away from unnecessarily purchasing these ACTs. I will say this is like a pretty new table. And so if you have thoughts on how this can be better presented, I'm very open to them. So would love your thoughts here. So that's, I would say, yes.
So why is there a separate positivity rate?
Yeah, so there are three different kind of groups of patients in the sample. There's the share who don't get tested at all. There's the share who test positive, and there's a share who conditional on testing test positive, and then those who are conditional on testing test negative. And so that's what these different pieces get at. So it's not the positive and negativity don't sum to one, if that makes sense. Okay, great. So basically kind of recap what we've seen so far. We find So I've been puzzling about this as well. So I think, yes, I think the tricky piece is that these are at the pharmacy level. And so kind of a higher positivity rate I'm not going to be able to disentangle sort of an individual, like if on average a person tests positive, they're going to do X. So I think it's a little bit essentially like there's some interaction between the higher positivity rate and a higher negativity rate, in the sense that there could be just more people who are actually getting tested. And so I guess it's a little bit, I don't know if this is making sense, but it's a little bit more complicated than I ideally would have liked, if that makes sense.
How many of them do you actually have a test?
About 9,000. Yeah. And then for I guess the other piece of this is that for the control group, as part of this, we did a random. So for those who didn't get tested through the incentives program, we don't have an individual test result. So that 9,000 comes from that group. For those that are, in the control group who may test, but we don't see their results, we use a combination of kind of administrative pharmacy level records of just positivity rates and negativity rates, from the pharmacies. And then we also conducted kind of an independent random testing exercise where we essentially randomly, kind of in a random subset of patients in the control group, did randomized tests to get at some of these, kind of try to piece together the different pieces of that puzzle. Okay, so those are kind of the high level overall findings. And so what we did was we looked at a couple of different mechanisms. So we found similar effects on testing and treatment across the patient discounts and the provider incentives. And so there's a question of, well, why is that the case? How are these incentive interventions actually working? And so what we found there are a couple of mechanisms at play, we think. So on the one hand, so this first table essentially shows kind of changes in prices to patients for tests. And what we find is that in the patient discount group, in fact, we actually find evidence of kind of the fact that these incentives actually made it to the patients in the form of reduced prices. So we see about a 43% decrease in the price of rapid tests in this group. Interestingly, we actually don't find any evidence that the incentives in the provider side arms actually resulted in lower prices for patients. And so, that suggests that kind of this price mechanism is sort of working in the patient side, the patient discount arm, but not necessarily in the provider arms. And so in order to kind of get at, well, what's happening in the provider arms, this is where some of the data from our standardized or our mystery shopper exercise kind of provided some of that context. And in particular, we think that the provider arms, or when we incentivize providers directly, we actually see kind of qualitative differences in how they're counseling patients. So this table is kind of showing that. So on the one hand, we don't find any effect because these data are from the 411 mystery shoppers that visited all 140 of our study sites over a 2-month period. Basically, they went in and were asked to present with complaints of sort of generalized fever and other flu-like, malaria-like symptoms, and then asked for the pharmacist's recommendations. And so from there, we were able to see kind of whether pharmacists recommended tests, how long they were able to, they spent with the patient, et cetera, and then kind of treatment recommendations and et cetera. And so what we find is that there's actually kind of interestingly in this group, we didn't find any differences in whether or not the pharmacist actually offered that mystery shopper a rapid test for malaria. We think this is because they went in kind of and asked for a general recommendation. I'm happy to talk a bit more about that if there's interest. And we didn't find any differences in kind of the mystery shopper reports of kind of pharmacist knowledge of how to conduct a test and also of knowledge around treatment options for malaria. What we did find differences in particular in the provider side groups, we found that there was actually kind of a much higher share of mystery shoppers who reported that the pharmacist actually took sufficient amounts of time to really explain the medication options to them and their treatment course. And so kind of some evidence that there's sort of differences in counseling that are being provided to patients, particularly when we incentivize providers or pharmacists directly. So that's kind of all for today. So just to kind of summarize what we talked about. So we looked at the effect of patient versus provider incentives on malaria testing and treatment targeting. And we find that incentives both kind of improve testing uptake through a price effect for patient subsidies and kind of counseling for provider incentives. And we do find evidence of kind of improvements in treatment targeting, particularly in large part due to malaria negative patients actually opting out of unnecessarily taking antimalarials. And so kind of in sum, this sort of suggests that kind of both the information that's being provided by the test, as well as the price of these different products and sort of the relative prices of these products matter when making decisions. I'll end there. So thanks for your time. And we have about 12 minutes, I think, for questions, both in the room and on Zoom. So happy to take them. Yeah.
You know the situation in epidemic malaria. And often the pharmacy then you say, the healthcare center, so curious. Before they come in, not necessarily but your experience and knowledge of why do people choose private pharmacies over the public sector? When RBTs and malaria are free.
Yes. Yeah, that's a great question. Yes, I have a couple of ideas here and based on. Oh, yes. Yeah, absolutely. Thank you. So the question was, in Western Kenya, in this context, pharmacies are often kind of co-located in communities with public clinics and sort of, different public sector providers. And so the question is, why do so many people actually seek care for these symptoms in the private sector? And kind of based on speaking with collaborators there and kind of seeing what sort of the realities of where people seek care, I think there are a couple of things at play. Number one is I think that especially in very rural communities, it's not the case necessarily that the public clinic or the health center is close enough. And these pharmacies, they range in levels of formality, but they're everywhere. Some sort of drug shop, some pharmacy is going to be a 5-10 minute walk away from where people live or work. And I think that's a really big driver of that decision. The other thing, and this was the case in a few moments during kind of when we were working on this, is there are sometimes stockouts of medicines and tests in the public sector. And you'll often even find cases where, public clinics will buy in bulk from the private providers in order to kind of offset some of these like ebbs and flows in medication testing availability. So I think that there's kind of these types of things I think are some of the most common barriers or reasons why someone might choose in the private sector. Yeah, transport's another one. So yeah, these are all things at play, I think. Yeah. Yes. Yes. So the question was, can I talk a little bit more about how we arrived at the incentive levels and then why in kind of the patient and provider arms, the total amount of the incentive kind of split between the treatment and the test, sum to $2. Yes. So in terms of the kind of initial setting of the incentive levels, these were determined through, with inputs from a few different sources. One was a series of kind of focus groups with target patient populations as well as providers to understand kind of, their perspectives on, pricing for these products. And we also looked at kind of the market data on looking at what common, in some ways like competitor products for these types of, for the medication that we were targeting and for the tests and the prices of those products as well. And so we, and this was all using kind of like market data from the local markets that we were working in. And so we, as an example, kind of a very common anti-malarial in this part of Kenya is about $1.25. And the medication that we were focusing on, kind of incentivizing in the study, was more costly. It was it was a WHO pre-qualified medicine, and this other one was not. And so that's kind of where that cost difference came. But we made sure that we kind of benchmarked against the cheaper, much more common alternative in terms of like setting patient prices. And then on the provider side, the other piece that we were quite concerned about or cognizant of is that, if we're thinking about pharmacist motivations, and one of the potential barriers to encouraging testing might be that they are worried about missing out on a sale, is that we wanted to make sure that as part of participating in these interventions, in these incentive programs, they weren't going to necessarily be losing out on kind of average profitability. And so sort of taking into consideration, those different factors were how we arrived at that. I hope that answers your question. Yeah, Sonia. So we captured all medication use. The only ones that were kind of incentivized or promoted by the program were the WHO pre-qualified medicines. But yeah, we know kind of the results that I showed today on just overall treatment uptake. That's all ACTs. That's not just the WHO pre-qualified. Yeah. Any other questions in the room or I see one in the chat. Let's see. Oh, okay. Okay, perfect. Oh, yes. Juan, please go ahead.
Hi, Maria. Love the presentation. So much work, really thought-provoking. So from somebody who isn't as familiar with financial incentives, I was wondering if you could walk me through, in this very specific context, when somebody is entering a pharmacy and has access to all these resources, the information, these materials, et cetera, where do financial incentives rank in other kinds of incentives that may be going through their decision-making process? And maybe a different way of asking the question is like, for us who do other kinds of public health work for different kinds of contexts, how should we think through financial incentives as we do multi-package set of interventions?
Yeah, that's a great question. Was that you all were able to hear that question? Great. So I think that I think that I guess a couple of things. So the results that we showed today were all like average effects. And I think that there's, of course, sort of different, there are a lot of different types of patients in the kind of overall that are not getting accounted for or a sufficiently nuanced kind of analysis when we're looking at averages. And so I think that for patients, depending on where they are kind of in the distribution in terms of, their own socioeconomic status or, urbanicity, kind of rural, there are a lot of different factors that may affect people's decisions and sort of the relative weight of the different types of, pieces that might go into that decision and how important they are. So, so I guess that's one piece. So I think that for financial incentives, in particular for patients, I think that in this case, so I think they matter for a couple of different reasons. I think for one, this is not, these product, tests and this type of treatment, these are already available in all of these sites. And so in some ways, like, this is not a question of trying to introduce something new. It's a question of kind of trying to make it more attractive to a patient to think about and to kind of take the time. And so in some ways, the financial incentive is aimed at kind of trying to, to kind of get at that aim. It's not the only way to do so. It's potentially one way. And may work better for some types of patients than for others. And kind of what I didn't highlight this explicitly, but is worth mentioning is that, we saw an increase to about 30% of patients in our pool that tested. There's still 70% of people who decided to that it wasn't worth their time or money for whatever reason, even at those incentivized levels. And so I think that one kind of interesting follow-up could be try to figure out, what are some of the differences in the patient population between the groups for whom incentives seem to matter and those who may be more nudged by other types of interventions. So I think it's a good question. And I think that I don't know if I don't have a super concise or global answer for how we should be thinking about this in a variety of different settings. I think this is where context really matters, and just being thoughtful about about both the intended and unintended consequences of kind of whatever incentive or intervention package one is doing. I would just say that feels important to me. So thank you. Yes. How do you do a malaria test? Great question. So the question was, how do you do a malaria test? How long does it take? So for these rapid tests, it's a finger prick and a drop of blood into a cassette, and it takes 15 minutes for waiting for that to read. It's basically it looks exactly like a COVID test, but instead of a nasal swab, it's a finger prick blood drop.
One of the incentives for doing this potential or growing anti-malaria resistance.
Yeah.
So what is the status of resistance to invasive
Yeah, it's a good question. So I don't know if I can't say specifically with Western Kenya, but there, and I'll pull a few. So the question was, what's the status of anti-malarial resistance or ACT resistance for this? Yeah. So we're starting to see evidence in not necessarily, I don't think evidence from Kenya, but Uganda has in the last few years has shown that there's been some more concerning rises in resistance. I think there's a big push now to think about kind of multiple first line therapies and looking at different types of medications that get at with the same active ingredients, but in different quantities, and with different kind of complements to try to get at that. But this is actually an area that I'm really interested in sort of thinking more about, and so hopeful that there's more work to be done in kind of getting at that in a better way. So great to get a chance to speak with you, and I hope you have a great rest of your afternoon.